Assalamu alaikum. So we'll start our first long case today, Dr. Mahmoud and Dr. Imaz. We have patient named Omar, 20 years old, came with complaint of headache. Please, Dr. Mahmoud, you can start after you see the timer. Just a minute. Timer. Stopwatch. Okay, you can
Hello.
start.
Hello.
Hello?
My name is Dr. Hussein, one of a medical doctor in clinic. Today, I'm talking to Mr. Umar, 20 years old.
Yes, yeah, that's me.
Mr. Umar, I'm here today with you to discuss some issue related to your health condition and examine you. And after that, I will do my best to address your question. Is that okay with you?
Yes, doctor.
Before proceeding further, if you have any question during this meeting, then don't hesitate to stop me. Okay?
Okay.
Mr. Omar, it came to my knowledge that you suffer from headache. Could you tell me more about that?
I've been struggling with the headache for so much time now, and it's just on and off.
I'm so sorry for that, and thank you for sharing this information with me. If I give you grade scale to grade this pain now from 1 minimum and 10 maximum, how you can grade it?
I would say it can become an 8.
I'm so sorry. I can offer you painkiller if you don't mind.
I'm sorry, can you say that again?
I can offer to you painkiller.
Oh yeah, they gave me some painkiller. Thank you.
Thank you. When this headache started exactly, Mr. Omar?
I'm sorry?
When this headache started exactly?
It started, I would say, I've always been struggling with headaches. I have always been having headaches for a long time.
For how long?
Years and years, doctor.
Years.
Yeah,
Okay.
since I was a child.
Did this start suddenly or gradually?
No, it was just gradual, really.
As you said that come on and off.
Yes.
Is this attack, recent attack, similar to that attack, first attack?
Yes, it's the same. But my GP now asked me to come and see you.
Okay. I'm so sorry for that.
Thank you.
How many attack per month or per in last years?
They're very random, but now I think I have them very often now. They because they cause some seizures for me.
I'm so sorry for that.
Thank you.
When attack came, for how long suffered from attack?
The headache or the seizure?
Headache.
It can just last for hours or minutes. It depends. Yeah.
For one. Do you have pain in anywhere in your body?
Pain.
Yes.
No, not really.
Okay. Also, as you said, also you suffered from seizure.
Yes, doctor.
Okay. How can let me to back to this headache? How can improve this headache?
I think sometimes painkillers sometimes help.
Painkiller.
Yeah.
Do you notice anything make it worse?
Recently, maybe coughing or sneezing.
Caffeine and sneezing. Okay. Do you have a weakness anywhere in your body?
No.
Okay. When bending forward, this headache increase. Do you notice that?
I didn't notice. I don't remember, to be honest.
Okay. This headache, the worst headache that you have?
I've always had headaches and they're always bad, but they're getting worse recently.
Also, you said to me that you suffered from seizures. Could you tell me more about?
Yeah, I've had like 5 seizures now, and my GP asked me to come and see you because he started me on some medication.
Okay. For how long this headache? When this seizure started exactly?
I had 5 seizures in 1 month.
Yes. When the first?
Last month.
Last month. During this last month for seizures.
Yes.
Do you lost your consciousness?
Yes. During the seizure, yeah.
Any person watch you during seizure?
Yes, my father was with me and my friends sometimes.
They told you that you lost your, sorry for this question, you lost your control of water work.
Yes.
Also, this frothy came from your mouth.
Yes, doctor.
I'm so sorry for that. Do you have any steadiness?
No, not really.
Altered sensation or loss of sensation or change in sensation anywhere in your body?
What do you mean, doctor?
Also, do you feel numbness, tingling, loss of sensation? You can't
No,
feel.
but I have this skin rash. I've always had this skin rash, but it's getting worse also recently.
Do you have skin rash?
Yes. You want me to show you?
Can I have a look to the rash?
Yes. The picture is in the group.
Okay. Do you have change in your water work?
No.
Changing color that your water work become reddish or like?
No, it's normal.
Change in frequency and amount?
No.
Burning sensation?
No.
Also, do you have vision problem?
No. Well, I think sometimes, yeah, I have some visual problems sometimes, like seeing double or something.
You see double?
Sometimes, yes.
Okay. Do you have dropping of your eyelids?
Sorry?
Do you have drop of your eyelids?
No.
When you cover one eye, the double vision disappear?
No. I didn't try this, no.
No. Okay. Do you have change in your nail?
Yes, as you can see in the picture.
Okay. Do you have any hearing problem?
No.
Hearing problem. Okay. Do you have chest pain?
No, doctor.
Racing heartbeats?
Sometimes, yes.
Could you tell me more?
I just have racing heartbeats. Sometimes. On and off.
On and off. On exertion or
Yeah,
when you play?
get worse with tiredness, yes.
with walking, huh? Okay. When you
I'm
walk.
sorry? Yeah, when I do exercise or walk up a hill or something.
When this racing of your heartbeats starts exactly?
I'm sorry?
When started exactly this racing of your heartbeats?
I've had it for like 2 years now.
2 years. Do you have short difficulty breathing?
Yes, when I'm doing things. I stopped playing football, for example.
I'm so sorry for that. Also, when lying flat or when
No,
do you gasp before air during sleep?
no,
Okay. Do you have cough?
no,
Do you have tummy pain?
no,
Tummy distension?
no,
Those change of your bowel habits?
no.
Also, do you notice that your eyes became more paler than usual before?
Not really, doctor, no.
Do you have do you notice any change in your eye color became yellow?
I'm sorry?
Your eyes become yellow?
No.
Okay. Do you have joint pain?
Joint pain? No.
Okay. Do you have a change in your weight?
No, I didn't notice change in my weight, doctor.
Night sweat?
No,
High body temperature?
no,
Weather preference?
no,
Feeling sick?
no,
Throwing up?
no. I feel sick
Three,
sometimes, but I don't throw up.
3 minutes
Throw up?
remaining, Dr. Mahmoud.
Let's meet to examine.
I'm sorry?
Examination?
Yes. This is the face, this is the nail. What else do you want to examine?
Okay. Vitals?
Slightly high blood pressure.
High blood pressure.
140/90, yeah.
Okay. Auscultation of do pronator drift?
Normal.
Auscultation of the chest?
Normal.
Palpation of the kidney, palatable?
No.
Liver, spleen?
No, normal.
Okay. Do you have any allergy to any medication?
No, not really, doctor.
Any past medical history or should be aware of?
No.
Show me your medication list.
I don't take really any medications. I just take paracetamol for the headache.
Are you drive?
No, I don't drive.
What's your job?
I work. I go to school.
What's your performance about your performance in school?
I'm struggling really, doctor.
I'm so sorry for that. I will offer help regarding this. Any similar condition in family?
Yes, my father had the same problem and he died early.
What's your concern, Mr. Omar? Sorry for your loss.
Thank you. I'm just concerned. What do I have, doctor?
I highly appreciate your concern, Mr. Omar. After I talk to you and examine you, most likely you have a condition called tuberous sclerosis. It is a medical term of medical condition in which there is, it is a familial condition, I mean run in families, associated with this rash in your face and this nail character, also associated with overgrowth in your brain and in other part of your body, causing symptoms that you have. So what we need to do is admit you and run some blood test and imaging for your brain and tummy, and after that I will refer you to a group of specialists in form of nerve doctors and social health worker and eye doctors and skin doctors to give you proper plan of management. Is that okay with you?
Yes, doctor.
Do you have any other concern?
No, thank you, doctor. Okay. Is time up? Because I can't see the timer.
Yes, Dr. Imaz, time is up. Please go to the examiner question.
Okay. So what was just give me a differential, please, doctor.
Differential here in view of this young male suffering from headache for long times and seizures and bad school performance and family history of skin rash and similar condition. My top differential here is complication of tuberous sclerosis.
Okay. Name two other differentials.
Regarding
Three
headache,
differentials with regarding similar presentations.
could be also neurofibromatosis, could be von Hippel-Lindau syndrome.
Okay. Give me three complications of this condition. Three renal complications.
Renal cyst.
Okay.
Okay. Can cause renal cyst and nephroblastoma.
Are you sure? Okay, what else?
And renal failure, chronic renal disease.
Exactly, renal disease. It can also cause renal tumor, right?
Yes.
Renal cell cancer. Okay, how are you going to manage this patient? And I mean investigation and management, yes.
Investigation, general investigation and specific investigation, and investigation looking for complication. General, I will do a full blood count and renal function test, maybe impaired liver function test, and serum electrolytes and inflammatory markers. Also, this general specific I will genetic test.
Okay.
Genetic test is complication, MRI of brain, and also I will do fundoscopy. I will do renal ultrasound. this regarding. Also, I will do echo and ECG.
Okay, good.
Okay.
Yeah.
Regarding treatment, pharmacological and non-pharmacological, pharmacological education of the patient and family about the condition. Also, refer patient to a group multidisciplinary team in the form of neurologist, ophthalmologist, and cardiologist, and nephrologist, and dermatologist, and also social workers, and also school education specialist.
Okay. Is there time for another question? What's the name of the condition in his nail?
Angular
Yes.
fibroma.
Yes. Angle fibroma. Okay. I can't see the time obviously because I'm Android, so I'm not sure whether do we still have time or not.
Still, yeah, 10 seconds, Emily.
Okay, good.
So if you're done, you can comment.
Okay. Dr. Mahmoud, how do you think you did?
What?
How do you think you did?
I think I did my best, but I don't know.
I think you did well. You got the diagnosis eventually. You were aware of the complications, and I think you asked most of the questions that were related to the complications. You just took too much history, and then on examination, you asked me and I answered so fast. But I think on the exam, you wouldn't have been able to examine all these things in 3 minutes and also deal with the concerns. So you need to be careful with the time management in taking history. You asked me too many questions. And I mentioned the epilepsy very early. Okay. Something else, I think you did the checklist in history. Perfect. You just missed examine the axilla for to exclude neurofibromatosis because it's one of the differential. Yes. So the axilla, and then you asked me for blood pressure, which was good. I think that you need to examine, which is something I don't think I would remember in the exam, to be honest. But if you saw this in my hands, the subangular fibroma, you need to ask me. You ask to examine the toes. So if the time's up, just tell the examiner I would like to examine the toes, or maybe in the management plan. I don't really remember other things that you didn't mention. But I think you did very well. MashaAllah, you did very well. It's just the time management, but other than that, you did very well.
Thank you.
Oh, and it's not hamartoma. I don't think they have hamartoma. They have heme, some angiomyolipomas. Oh my God, angiomyolipomas. Yeah.
Yeah, myeloblastomas in the kidneys.
Yes. And then the complications, because they have cyst, you can say cyst rupture, cyst infection, cyst hemorrhage, renal cell carcinoma, and renal failure. And you should look for any signs. Obviously, ask me, and I said I don't have any past medical history, but you can look, just pretend that you're looking in the arms, looking for any fistulas or any renal replacement signs. But I think, mashallah, you did very well. Thank you.
Yeah, thanks for the case, Dr. Rimaz. Will perform as Dr. Mahmoud. So almost the same comments. You cover all the system review and the history very well, but you took little in the CNS and the complaint. The onset course duration you cover well on and off the scale, and you ask for the scale and you offer painkiller, which is good for the welfare. The analysis for the long duration you ask well, what improve, what worse you ask as well. The frequency, very important here. So once you discover that it started since the childhood, you have little target differential. But once Dr. Rimaz mentioned the seizure, you can't put for example, the one for eye tearing, what's called cluster headache. Yeah, it comes since long time, the migraine as well. But the headache, the seizure now will be targeting for the tuberous sclerosis. So let's go to other system review. The seizure you analyze the last month worse, and you ask what increase, what decrease, the unsteadiness. I think you covered most of the CNS, and which is good. Vision you asked, and she had double vision. Hearing you asked as well. So it's very important here to rule out von Hippel-Lindau as a cerebellar will be affection or affected. Once she mentioned for you the skin rash, you saw it. So it helped you again for the differential and for targeting the case. You ask for the other system up, downward, I mean from cardiovascular, respiratory, you ask, abdomen history, you talk well. Then the constitutional symptoms, you ask plate inside the system U, it's okay. Eye color, either pallor or jaundice, to rule out any anemia or affection of the liver, which was good. The nail change and joint pain, you ask. Endocrine also you ask. Family history late, you ask. So at least you asked. The travel no need, medical and medication, you miss that medication, or you ask, I'm not sure. And so all this uh, you did well, but the problem, the examination, as Dr. Rimaz mentioned, the examination was little less because what you have to examine here in this patient, a lot of things, starting from the brain, from maybe the eye itself, to roll out any eye changes. And also you can ask for the CNS examination, the balance, the gait, if to rule out certain complication or association. The skin, very important to examine here, starting from the chagrin patch in the skin, coffee ole, ash leaf spot, and adenoma sebaceum in the face. One important you ask also in the history learning difficulty, which was good. The job student smoking alcohol, you didn't ask. Sometimes, and I think in this case it's important to reduce it if he is on. Driving also very important you ask. Sorry, I went back to the history. Now the examination. Okay, back to the examination. You ask a lot of, you didn't examine. Actually, you didn't examine most of the systems. At least show the examiner that you examine the skin, because most of this lesion in the skin. Other lesion will be in the kidney, and you can ask by the history or urine dipstick at the end of the case. Apart from that, you did well. You reached the case.
target examination for eye complication and auscultation of the heart, but palpation of the kidney.
Sometimes yes, the heart will be affected. Yeah, palatable kidneys. You ask, yes, I agree, but it was little short. By any way, you did well because you reached to the diagnosis and the case. Little bit spot diagnosis. You can reach diagnosis from maybe after 3 to 4 minutes. When she mentioned the seizure, you can reach the diagnosis. So the investigation, starting by general, specific, and complication and association, you did great. Basic workup, baseline workup, CBC and electrolyte, urea, creatinine for the kidney affection, and CK is important, CPK for the seizure, and you can add also EEG as well. The MRI for the brain, you can even CT, you can see the tuberous in the brain, tubers. The echo for complication, ultrasound, yes, for the kidney, and the renal cell carcinoma on also with the complication. You can ask or you put in the differential and the complication. So our differential in this patient, as Dr. Rimaz mentioned, tuberous sclerosis and neurofibromatosis, von Hippel-Lindau, all of them can be rolled out by history and by examination. To confirm diagnosis, you do genetic testing. I guess we can add here also complex seizure, but against that, the headache will not be there. But still, it can be as a differential of seizure in young age. The management, Dr. Rimaz didn't ask you. There is, as you said, non-pharmacological and pharmacological education counseling. And here you can talk more about epilepsy, red flags, and safety netting. Patient will have seizure, he should be monitored all the time. If he had the epilepsy attack anytime, he might be in danger. So you could give some advice about that. So about the pharmacological, there is medication called sirolimus. It's motor kinase inhibitors. And it's like immunosuppressant in tuberous sclerosis. And the drug choice of anti-epileptic in this patient, Dr. Mahmoud, what do you think? Will you give this patient carbamazepine?
What?
The drug anti-epileptic medication or anti-epileptic drugs of a choice in this case. Carbamazepine?
Vigabatrin, I think. Vigabatrin.
Yeah, vigabatrin. Yeah, vigabatrin. Yes, this is the drug of choice. Yes, but avoid carbamazepine and phenytoin is not because it's worse than seizure.
Yes.
Carbamazepine and phenytoin. Vigabatrin and the drug of choice. Topiramate, lamotrigine can be given as well as valproic acid. And yeah, genetic screening for the family and for the sibling, but already patient is diagnosed. Maybe for the genetic counseling about child or getting a child or children to be screened for the future. I guess we covered. Sorry, I can't hear who's talking. Sorry. Hello. Okay. If no comment and question, anyone has comment or question? Hello. Any question? Any comment for this case? Chat box. Differential seizure in young, could you enumerate again? Yes, Dr. Ihda. So tuberous sclerosis, von Hippel-Lindau, and neurofibromatosis. Complex seizure. Complex partial seizure can present with the same. Focus examination is a lot here, Dr. Dalia. Prioritizing to complain is the best. CNS first, then skin, then heart, due to palpitation. If still you have time, do abdomen. Yes. Yeah, I guess Dr. Mahmoud did target examination and it was very quick examination. So I will not minus you in the examination, Dr. Mahmoud. What you did was perfect. Either the history or the examination, even the examiner time, you were really great. Okay, if no more question, we can shift to the next scenario. Can you give us the scenario, Dr. Mahmoud?
Okay, I will write here.
Dr. Rabia, are you with us? You want to add any? No, she's not. Dr. Rabia, are you there? So the timer now appear for all.
Yes, I can see it now.
It wasn't before, right?
No, I couldn't see it earlier. Maybe
Yeah,
somebody,
I
other
didn't.
people could
No,
see it.
no, I didn't share it. Now I
Oh, okay.
share it late. It's okay.
Okay.
I will try to find solution to share the image while
You can
using the
actually
Zoom.
share the image.
Really? It's not
Yeah.
affecting the recording? Okay.
No, there is a, the button that says share.
Yeah. Okay, so it will not affect the record. Okay,
It will come on the record.
okay. So, Mr. Ahmed, your patient, Dr. Ahmed, Dr. Ahmed, Mr. Ahmed, 56 years, complain of short breath for 2 months. Just
Okay.
take 2 minutes,
Okay.
then we will resume. Okay.
His vitals.
Okay, maybe he will give you in the examination.
Huh?
Okay, stable.
Normal.
Yeah,
Yes,
stable, he
normal.
mentioned.
Yes,
Okay.
normal. Normal.
Okay, great. Thank you.
So I will share the image for the previous patient just for the recording. This is his face, and this is the nail changes. Subangular fibromas. And this is sebaceous adenoma.
I can't see it. I'm not sure if other people can.
Yeah, it isn't, it's not there. You mean?
I can't see what you're sharing now. Maybe others can.
No, I can't.
So did you see the button, the one that says share?
Yeah, I did share, but I think it's not allowed. Maybe the record is not allowed.
Oh, I do it all the time in the records and it comes. Because I teach for living, so.
MashaAllah. Great. It's okay. I will find solution for that. Is it sharing now? You can see the screen. Still? Stop share device.
No, it's
Can you
sharing.
share?
You are sharing the screen. We can see what you're
Yeah,
sharing. We can see
yeah,
your
see.
screen.
So now you can see
Yes, we
the
can.
image?
Yeah.
Okay. So just for more clarification, this was for the patient, the previous patient with tuberous sclerosis, adenoma sebaceous, and subangular fibromas. Just to be in the report. Thank you. If you're ready, Dr. Imaz, we can start your case now.
Okay. Um,
Okay, ready?
hello?
I will show the time.
Yeah. Okay, hello?
Okay,
I don't think Dr. Mahmoud is around.
Sorry. Hello.
No, it's all
yeah,
right.
let's
Hi. Good afternoon.
Good afternoon.
Hi, Dr. Mahmoud. This is, sorry. Hi, Mr. Ahmed. This is Dr. Turkawi. I'm one of the doctors in the clinic today. I just need to confirm your age. Are you 56 years old?
Yes.
Okay. So tell me what seems to be the problem.
Actually, doctor, I suffer from difficulty breathing
Okay. And how long has it been?
for 2 months, I
Okay.
think.
Have you had it before that?
Again,
Have you had the shortness of breath any time before that?
no.
Okay. And
Always
did
first
it
time.
start suddenly or gradually?
Gradual.
Gradual. Okay. And so is it getting worse now?
Yes, with time.
Mm.
It started before 2 months, and now I think increased.
Okay. And what about is it getting worse with movement or what makes it worse?
Yes, with movement, I noticed that increase.
Okay. What kind of movement? So how far can you walk before you start being breathless?
Walking in the street also, I suffered so much.
Okay. Do you work in the middle of the night with breathlessness as well?
No.
How many pillows do you sleep at?
One.
And if you've always been sleeping on one pillow?
Yes.
Okay. What about breathlessness? Does it get worse when lying flat?
No, I think in all positions same, doctor.
Okay. All right. And is there any cough with it?
Yes.
Okay. And do you bring up any phlegm?
No.
What about blood?
No.
Okay. And have you did you travel recently? Any long trip 2 months ago or before that?
Yes. Before in this 2 months, I'm not traveled, but before 1 year, I traveled.
Okay. And where did you go to?
I I went to I traveled to Pakistan.
Okay. Okay. And did you have any contact with anyone who had chronic cough or cough for a long time?
No.
Okay. With this cough, Mr. Ahmed, do you have any night sweating?
No.
Any fever?
No.
Any shivering or chills?
No.
Any weight loss?
No.
And have you been told that you look pale?
No, I didn't notice.
Any lumps or bumps?
No, lump or bump.
Okay. And do you smoke, Mr. Ahmed?
Yes.
Okay. How many cigarettes and for how long?
Socially, sometimes 4 or 5 for
Mm,
this last 2 years.
for 2 years. Have you ever smoked before that?
No.
Okay. And what about chest pain? Do you have any chest pain?
No.
Okay. Any noisy breathing?
No.
Okay. And you said that you don't have any weight loss. Just to confirm that, no weight loss at all.
No.
No. Okay. Have you ever been told that you look pale?
No.
No. Okay. What do you do for a living, Mr. Ahmed?
Now I'm not work.
Okay. What did you used to be?
What?
What did you do before now?
I am a farmer
Okay. And why did you stop working?
because of this shortness of breath or
Okay.
difficult breath.
Okay. And do you think you were exposed to any chemicals or
No,
no?
not
Okay. How long have you been a farmer?
for a long time.
Okay. And when did you stop?
This before 2 months. This because of difficulty breathing. I suffered so much and I can't do my job.
Okay. All right. And what about past medical history? Are you known to have any medical history?
Yes, I have high blood pressure and high blood sugar.
Mm. Okay. And are they controlled?
I think that
Okay. Any past medical history of any tuberculosis, which is a very prolonged chest infection?
no.
Okay. And you've never heard of anyone that you know who had tuberculosis or TB?
Yes,
Yes, as in yes, I have, or yeah, yes, I haven't.
I haven't.
You haven't. Okay, good. Okay. So you take what do you take for the diabetes and the hypertension?
For hypertension, I take lisinopril
Mm-hmm.
5 milligram. And for diabetes, metformin and glycoside.
Okay. Any other medications?
No,
Okay. And any over-the-counter medications?
no,
Okay. Any joint pain?
no,
Skin rash?
no,
Any weakness anywhere in your body?
no,
Muscle pain?
no,
Okay. Do you feel that your legs are swollen sometimes?
no, I didn't notice that.
Any swelling in your tummy?
No,
Any awareness of your heartbeats?
no,
Okay, I'm going to start. I will start examining you. I hope that's okay. And then I might ask you some questions.
okay,
Okay.
sure.
Okay. So looking at the patients, is he tachypnic?
No,
No, he's sitting comfortably. Okay. Any clubbing in the hands?
mild clubbing.
Mild clubbing. Okay.
Yes,
And any cyanosis?
no,
Okay. What about the pulse?
90 regular,
I'm sorry.
90 regular.
Okay. Pulse is 90, good volume. Any proximal weakness on examination?
No,
Okay. And eyes? Any pallor? Jaundice?
no,
Did you notice any dryness in your mouth or eyes?
no,
Any difficulty swallowing?
no,
Okay. Looking at the mouth, raise up your tongue. Any cyanosis? Any ulcers?
no cyanosis, no ulcer,
Lymph nodes in the neck?
no lymph node,
Any thyroid?
no,
JVP?
no.
Listen, so chest movement?
What? For what?
Chest movement, decreased, increased, normal,
Decreased,
decreased where exactly, or bilateral?
bilateral,
Bilateral decreased chest movement. Okay. What about air entry?
normal,
Normal air entry. Any added sounds?
these crackles,
Where?
lower zone,
Lower zone, bilateral or unilateral?
bilateral, bilateral.
Bilateral. Okay. Yes. And what about percussion note? Just gonna do it, but
dull.
okay, I'm gonna ask him to say 99 as well, but I don't really care about it. Okay, so I'm going to listen to the epic speed as well. Normal, not displaced, no second pulmonary heart sounds, right?
Normal. Skip it.
Okay, and then examining the legs for edema.
No edema.
Okay. Okay, so Mr. Ahmed, have you ever worked in a factory?
No.
Have you ever been exposed to asbestos?
No.
Okay. So have you been working as a farmer for your whole life?
No. It's for 3 years. Last 3 years.
Okay. And what about before that?
Before that, taxi driver.
Okay. And who do you live with, Mr. Ahmed, if you don't mind me asking?
With my wife.
Okay. And does she have any symptoms?
No.
Okay.
At all.
And are you well supported at home? Do you think you might need some help? Physical
Thank you. No.
mobility?
I'm well supported. Thank you.
Okay, that's great. So I'm sorry. When I examine the lungs, I was just gonna ask him to take a cough. The crepitations are gonna still be there, right?
Yes.
Okay. And does he have any wheezes?
No.
Okay. All right. So what are your concerns, Mr. Ahmed?
What's wrong with me?
Okay, that's a very valid question. So Mr. Ahmed, I can see that you're worried. Your breathlessness is might be actually due to lung scarring in both lungs in the lower area, and it can be actually related to your previous job where you used to work in the farms. Um, um, we will need to admit you to do some blood tests and to just check how much oxygen do you have in your blood. And we need to do some advanced imaging and CT scan. And we might need to also do some breathing test, ask you to blow in some devices, if that's all right. Would that be okay?
Yes. Okay, doctor.
Okay. And do you have any questions for me?
Also, I suffered from also a burning sensation in my water work many times. This may be related to my condition.
Burning sensation.
Yes.
We will need to take a sample of your urine, and I will get back to you on that. Would that be okay?
Okay, doctor. But when I went to my GP also, he gave me medication many times, and this my condition improved. This
For the waterwork infection, how many times did he give you the medication? Because I think you mentioned that you're not on any medication other than the... Okay. What's the name of the medication? Is it nitrofurantoin?
maybe like this, doctor. I'm not sure exactly.
Okay, it's all right. It might be also related to this medication. It might be related to your job. It would be difficult to tell until we do the investigations and to do the imaging. Some areas, some offenders tend to cause the lung scarring in certain areas in the lung, but there is no cutoff. So it might be related to this repeated exposure to the same medication also. Okay. What
Okay,
about
doctor.
smoking, Mr. Ahmed? You said you don't smoke, do you? Only the 4 to 5 cigarettes.
Yes. Yes.
Yeah, I highly recommend that you will need to stop smoking, as it will definitely make your lung scarring worse, and it might make your condition worse as well. Would that be okay?
Yes. Thank you. I will think about this issue.
Okay, regarding your breathing, we will involve a team of doctors and nurses to look after you. We will get the breathing doctors, we call them respiratory doctors, and the breathing nurses as well. They will assess your oxygen in the blood and your condition in general, and they might start you on medications as well. You will have support in form of occupational therapist who can help you with mobility issues, and maybe the respiratory nurse can assess you if you need oxygen or not at home. And the occupational therapist might help adjusting things at home for you to make things comfortable if you're struggling with stairs, for example. Okay?
Okay, doctor. Thank you.
All right. Thank you so much.
Okay, examiner time.
Yes. What's your differential?
Okay, so this is a 56 years old gentleman who presented with subacute onset of breathlessness that's getting worse with exertion. Uh, uh, he had been to Pakistan last year, however, could not appreciate any signs of tuberculosis. But he worked as a farmer and he had repeated exposure to probably nitrofurantoin. We will need to check with the GP. Secondary to urinary tract infections. So the top of my differential would be lung fibrosis. Probably lung fibrosis, yeah. But it could also be allergic bronchopulmonary alveolitis. It could also be tuberculosis, but the latter two are unlikely.
What do you think the cause of lung fibrosis in this gentleman? Most
As
likely.
I said, the repeated exposure to nitrofurantoin. We need to confirm the medication first with the GP and confirm the courses. Also, working as a farmer, the previous job can also have an effect.
Okay. How you can manage this patient?
So I will start by the non-pharmacological part, educate the patient about the lung fibrosis and how it will limit his life. Try to involve the occupational therapist, the respiratory nurse, respiratory consultant as well, and involve him in any kind of education and spreadsheets. I can also get the pharmacological part, which is after confirming that it's lung fibrosis, starting him on the pyrifenidone, and look for other medications that are now considered for lung fibrosis as well.
Okay, proceed.
However, I will need to admit the patient and treat him in an ABCD approach. Make sure that his airways are patent and that he's breathing normally. He does not require oxygen. I will need to do an bedside arterial blood gas and bedside baseline ECG. We need to do a chest X-ray with an high resolution CT scan, a full blood count, renal function test, and liver function test, just looking for any anemia or high infection markers. Any eosinophilia, trying to look for a cause. I would also need to do a pulmonary function test, expecting it might be restrictive in nature. Yeah.
What about treatment, medication?
As I said, so there is the pyrifenidone. Is considered as an option, but there is also ibrutinib, I think.
What?
Something tinib, but I don't remember. Sorry, it's a biological treatment. Yeah.
90 dinib.
90 dinib, yes. Sorry.
What's better in pulmonary function test you suspected?
I would expect a restrictive way, a restrictive pattern. which is going to be a high FEV1 over FVC ratio.
Okay. Okay, thank you.
How high is it, Dr. Rimas?
Over, I don't know. I don't really
Yeah,
know.
try
Like,
to remember. So the
yeah.
difference between obstructive and restrictive, how low the restrictive will be and how high the
Oh,
obstructive, sorry, yeah.
the obstructive that is easy. So if in obstructive, I would look at FEV1. If
Okay.
it's less than 80%, I will start considering mild, 70 to 80% decrease percent of the expected ratio, and
Don't
then
mix.
50 to
This is
70
for,
is moderate.
no, this is for
That's for the
COPD
obstructive.
grading. Yeah.
Yeah,
Let's.
yeah.
Okay, I'm talking about
What's
the different. Yeah, sorry, Dr.
what?
Mahmoud. I just to clarify this point only for Dr. Rimas.
Mhm.
What the difference between restrictive and obstructive in the result of forced expiratory volume 1 divided by forced volume capacity?
So in FEV1 over FVC
Yeah.
would be high in restrictive. I would expect the FEV1 to be decreased, so the FEV1 over FVC will be decreased in obstructive.
Less than 70, okay?
Yeah,
Less than 70.
I would.
And
I
the
would.
restrictive one, mostly maybe more than 70 or 80,
Okay,
okay?
80. Okay.
Yeah. Okay, let's
Um.
start the comment. Any other point you want to add?
Yeah, I just
What?
wanted to add the TLCO as well.
Yeah. Okay, Dr. Mahmoud, okay, tell us about telco. Yeah, tell us about telco. It will be
I would expect
in
it
this
to be
case.
low.
Yeah, exactly. Okay, so we'll start Dr. Mahmoud comment, then I will comment.
Yes, Dr. Rimashi did well and great, but in systemic review, she missed renal and GIT. Renal very important. If she asks, I, uh, I will tell her that I suffer from this recurrent infection and receive medication for this recurrent UTI. But other, she did great and perfect.
Thank you. Thank you.
Okay, thanks, Dr. Mahmoud, for the case. Well performance, Dr. Rimaz, as usual. And as usual, you miss a system which affects the whole case.
Yes.
Yeah. So my repeated advice to you, go system by system. Because
Yeah.
you miss only the GI. I wrote here in my paper.
And I had
You went,
time.
yeah, you had a lot of
Yes.
time. Try to go downward from up. System by system, you'll never miss any system.
Yes.
For example, you ask for the CNS wall, you ask for the endocrine, you ask for the chest, for the respiratory, for the abdomen, and you jump to the to the skin and joint and muscle pain. You miss the only system can guide you to your case, and it will harm your mark.
Yes.
And you ask everything in the case. You did very well about the constitutional, the travel history. You explore most of the things, but the system missed or the miss system, yeah, misguide you. So please don't miss. Okay, so I will start comment from the beginning. Short of breath as onset course duration, you covered well. Previous attack, you asked gradually what worse, what improved, how many pillows you are using, what about lying flat? Everything was okay. I mean, by the questions, but of course, it was short of breath in all positions, not related to certain position. It works with movement, of course, because it will make him more short of breath when he move or walk. You ask for the respiratory other complaints, I mean, associated symptoms like cough. You rolled out any phlegm. It means that he has a dry cough. No phlegm. You ask for the alarming of the cough I mean the blood in the cough to rule out certain infection or PE. And directly you went to the travel, which was very wise to ask for travel in this patient, either to rule out PE or to rule out serious chest infection, which might be TB if he has history of sick patient contact, especially he went to Pakistan. Then
Yes.
the constitutional symptoms, you ask about lumps and bumps and appetite and weight. Uh, pale, anyone told him that he paler than before, the lumps and bumps and the night sweats, temperature. So it's not infection in this patient. Then system by system, cardiovascular, you ask for the awareness of heartbeat. Before that, you ask for the noisy breathing, which was important in this patient to rule out asthma. Noisy breathing, you ask, it was a great question. CVS, cardiovascular system awareness, chest pain, no. Abdominal examination, sorry, abdominal system, you ask. And when you reach to the genitourinary, you skip and you ask for the skin and muscle and joint pain.
Mm.
The medication and the long-lasting disease, you ask for hypertension, and you rule out any medication can cause that. It was lisinopril, metformin, and glycoside. And you should ask if he added another medication and the compliant to the medication or missed the medication. And you can ask, by the way, in the control of blood sugar, how is your diabetes? Is it controlled? What about your 3 months reading of blood sugar? Just rule out he has some uncontrolled diabetes and he might have chest infection because of that. Immunocompromised, I mean. Allergy and surgery, very important in this patient. Allergy and surgery. Allergy because you might give him some medication if he has infection. So you can rule out any allergy for antibiotics. And surgical if he has any previous surgical history for lung condition, especially if he's bronchiectasis or whatever the possible cause of surgical removal of the lobe or whatever. You miss HIV totally, and it might be there.
Mm.
I mean, yeah, you can put here BCB pneumonia, right? Dry cough, a typical presentation. If he is risky for HIV, but he's not, you're lucky that he's not HIV patient or he doesn't have any history of HIV or contact with, for example, HIV patient.
Yes.
Sorry, partner, or you can ask for the casual relationships, recreational drugs. So if you follow the systems and the approach, you will not miss anything. But because you didn't follow in this point, I mean, HIV very important. You can put or you roll in or roll out some certain infection like BCB pneumonia or immunocompromised mean pneumonias. Okay, let's go to the job. You asked for the farmer, and it was 3 years only. And you didn't ask important question in his career while he's farmer. What do you think you missed? And you mention it in the differential. How you mention it in the differential and you didn't ask about it?
The what?
The what? He's farmer. What do you think the farmer will contact with? The birds?
Do you mean chemicals?
You
Oh,
asked for the chemical. Yeah, you asked for the chemical, but you didn't ask for the birds. The birds and the product of the
oh,
birds. And
yeah.
you mentioned in the differential ABBA. So it was very nice and very
Mm.
uh, good differential to put ABBA as a differential allergic bronchopulmonary alveolitis, but you should rule it out. You have, mashallah, good time to ask. You
Yeah,
can
it
ask
had to.
exposure to any bigon or any parrot, either in the farm or as hobbies. So it makes sense to ask about these things, right?
Yes.
Okay, so the birds and brucellosis. I don't think brucellosis as a milk product, as he is farmer, can be causing the chest infection.
No,
I
no,
mean
I never mentioned the brucellosis. Yeah.
yeah,
And he
brucellosis is
didn't
a
have
back
any
pain, and
fever, any sweating, any weight loss, or any
yeah,
lumps or
yeah,
bumps. So it was
yes,
off the
yes.
list. Yes.
Yeah, smoker, you ask, alcohol, maybe you ask, I'm not sure, but it
Mhm.
doesn't matter. Okay, so our differential in this patient will be, or before going to the differential examination, you did very well. Vitals, the pulse, the clubbing. Also, you can add tremors. if he is respiratory failure, it will be there, or
His
it would be
vitals
there.
were normal.
Yeah. No, the tremors, flapping and fine tremors. If respiratory failure, I mean. But clubbing was there. Lymph node, very important you mentioned. And direct, you go to the chest examination, inspection, palpation, percussion, auscultation. By palpation, limited expansion bilaterally. And for the percussion, there was dullness in the basal zone. The auscultation, sorry, the percussion will finish. Inspection, no scars, of course. Palpation, percussion, auscultation. Auscultation, you ask for the crackles, and you discover there is crackles. Then you miss to ask the cough. However, you ask it later. It's okay. So whenever you hear, I am repeating this because it will guide you either fibrosis or pneumonia, like the case of Thursday. Course, crackle in the patient, ask him to cough immediately. Don't miss it.
Oh
If
yeah,
you
I
have cough,
asked him
yeah,
very late.
late. Yeah, it's okay. So, yeah, it was there by Basil. It guide you to the diagnosis. The heart, but you miss also important complication related to fibrosis. What do you think, Dr. Imaz?
I'm sorry?
Fibrosis for long term, what will cause as a complication? What do you think?
Fibrosis for long term? Death?
Yeah, pulmonary hypertension?
Yeah, no, there are no signs of pulmonary hypertension.
You did the
I
loud
did,
B2
yeah.
and paroxysmal heave? I guess
Yes,
you also,
personal heave and pulmonary heart sound as well.
okay. So it's important here also leg edema for DVT
No,
and
no leg
PE.
swelling.
Yeah. So if there is edema, what you should do?
I would think
If
of
you
heart
dis
failure, so the uresis and oxygen.
Yeah, I know, I mean unequal leg swelling, what you could do if you have unequal leg swelling or leg edema.
Unequal, as in DVT,
Yeah, so you'll
subacute
think about
PE.
DVT, yeah, and
Oh
you'll think
yeah, I
about
thought
PE.
of it. So when he said I traveled, I was like, okay,
Yeah,
I got it. So
yeah,
he definitely
yeah,
have subacute BE, but then he was like, I went there 1 year
yes.
ago. So
Yeah, it's out. So our differential here, either pulmonary fibrosis, mainly due to drug exposure, which is nitrofurantoin, so drug-induced. Uh, Idiopathic could be there, but if the patient, it's more in the females, but still you can add it. And allergic, as you said, allergic bronchopulmonary alveolitis and occupational alveolitis. This is our differential in this case. So you did great, Dr. Rimaz. Dr. Mahmoud also did great in his case.
thank you.
Yeah, thank you all. If any comment or question, we can listen to you all. And any message here? What are the main differential in this case? Yes, I mentioned. She checked on examination. Yes, Dr. Zain, thank you for the comment. If any question, any comment? Why the people today less active? Or the case is so clear? Okay, if no question or no comment, we can go to the
Sorry,
communication. Yes, Dr. Mahmoud. Yeah.
in this case, also explain to us, don't forget any system. A small part from history can lead to misdiagnosis.
Yeah, can you raise your sound, please, again and repeat?
In this scenario, also
Yeah,
explain to us to complete our
yes,
uh,
yes.
history, because
Hmm.
the small part may
Yes,
make big problem.
yes, yes.
Yes.
Yeah, I agree with you. This is the take-home message for Dr. Rimaz. Every system should be asked
I'm
in
sorry,
any
can you say
scenario.
this again?
Yeah, he's saying any system can guide you to your case. So try not to miss any system, maybe related to certain system. Only point missing is the previous COVID infection. Yeah, Dr. Dalia, always giving us the golden points we are missing. COVID infection, yes.
Yes, yeah.
Okay, so the COVID itself or COVID vaccine now? Nowadays, there is some rumors about vaccines. Okay, so COVID, we'll put it in our mind for any case with chest symptoms. Dr. Dalia, you want to add another COVID-19 infection? Yes, agree. Okay. Okay, Dr. Roda? Dr. Roda and Dr. Who else for the communication?
I'm here.
Yeah. Are you ready?
Yes, hello.
Hello, Dr. Roda, how are you?
I'm
Are you
fine,
ready
thanks.
for for your case communication? Who
Yes,
was
ready.
with you, Dr. Roda?
Please send me the case.
Okay, wait, who's with you?
Dr. Sarah, I think.
Yeah,
Yes,
Dr. Sarah, are you there?
yes.
Okay, great. So we can start.
I will post the case
Can
in the group.
arrange together, then start, please.
Okay.
Okay, Dr. Dalia added vaccination. Vaccination high risk for infection as a higher risk of infection. I guess nowadays the vaccination risk for thrombosis. Yeah, for thrombosis, yes. Strokes and venous thrombosis. Cerebral venous thrombosis. Okay. Who will start? Dr. Roda, you write your scenario?
Yes, in the
Yes,
group.
yes. I will read it loudly.
Yeah,
You are a junior
please.
doctor working on a general medical ward. 65 years old man is admitted to your ward from emergency department following an unexplained syncope while shopping. There has been no previous episode, and since his arrival on the ward, he has been alert and oriented with normal observation. Physical examination and investigation, including ECG with chest X-ray and blood test, including troponin, at 12 hours after the collapse, have been normal. His telemetry up to this point has shown no abnormality. The plan agreed after consultant review on the ward round is to discharge him home with arrangement for an outpatient 24-hour tape and echo. Your task is to explain to his wife the uncertainty of the diagnosis and what the management plan is likely to be.
Okay, 2 minutes, then we can start.
Okay. Dr. Rhoda, are you there?
Yeah, and Dr. Sarah named the patient any name, even the wife, any name.
What?
Like give them the name you want, okay? Because the names are not written.
Oh,
Just
oh, okay.
Okay, let's assume Lisa, okay? Mrs. Lisa. Okay,
Okay.
this is the wife, right?
yeah.
You will sit with the wife. Yeah. And the patient
okay.
name, okay, will be John. Lisa and John,
John.
okay?
Okay.
Lisa and I will share the timer. Wait.
Okay. Hello, I am Dr. Ghanem, doctor in the clinic today. Are you Miss Lisa, wife of Mr. John?
Yes, doctor, correct.
Hello, Miss Lisa. We are here to discuss some issue related to your husband health condition. Is it okay with you?
Please, doctor, thank you.
Okay. Before we start, if you need anyone to be with you in this meeting, just ask. Okay.
I'm all right, fine, doctor.
Our conversation will be confidential. Okay. Okay. During our conversation, if you want to ask any question, don't hesitate to stop me and ask. Now, can you tell me how much do you know about your husband's condition?
Yeah, doctor. My husband actually has been admitted to this hospital because he has lost his consciousness, and actually he hasn't got it before. It's something like very scary. That is why he has been admitted to this hospital. I don't know why.
Okay. I'm so sorry for your husband's condition.
Thank you.
Okay. And what are your expectation about our meeting?
Actually, I don't know, doctor. This happened suddenly while he's shopping. Nothing in my mind.
Okay. Now I will please tell me this is first time to have this condition as you told me, right?
Yeah, doctor.
Okay. This condition, this syncopal attack or losing his conscious.
Mhm. Yeah, I'm with you, doctor.
Okay, we done a lot of tests,
Mhm.
like scanning to his chest and the blood test,
Mhm.
and these tests were normal, and this is a good point. Okay,
Thank
and
you, doctor. It is a kind of a relief, really.
yes, it's kind of a yes, but we will arrange some more tests to just to be sure about his condition. Okay. We will do uh, electrical taping to his heart and
Okay.
to scanning to his heart also. Okay.
Okay, doctor.
Um,
You are not sure about your what is going on. Why you are going to discharge him from the start?
we are going to discharge him as he is his test normal and is okay or assuring, and there is nothing dangerous we are afraid of.
Okay, doctor. I understand now.
Okay.
Okay.
But we will do, we arrange another meeting and ask him to come to the outpatient clinic to do other tests, just for following up and to know more about his condition. Is it okay?
Okay, doctor.
Mhm.
Doctor, does this mean that this will not never happen again for him?
Do you have any concern now?
Y- Yes, doctor. Does that mean this condition will not happen again? That is why you are going to discharge him?
Now we are not sure about this is will gonna happen again or recur or not. So that we will do another test. We will arrange another test to do for him and to see how his heart is how the condition of his heart um, and to follow him in the outpatient clinic. Okay.
Um, okay, doctor, but doctor, he lives alone, doctor, actually, because my job is in another city, and when they told me that I came here to see him, but I don't know if he lost consciousness while he was alone, while he is alone. I don't know what is going to happen.
Yes, that we are going to talk about. In at home, he need to have someone with him, and I want to ask you, is he working?
Uh, Actually, he's retired.
Okay. And he you just said to me that he is living alone. So
Alone.
is it any possibility that you can put him in a nursing home?
No, 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 no. We
Why?
can no, no.
Why is that?
Doctor, we have a single house with a 13 room. Why do we need to put him in a nursing home?
Um, I appreciate your feeling, but nursing home is very good for people with that age, and this is not a bad thing for him. They can take care of him. They can give him his medication. They can take care of even his food and his cleaning, everything, and he can meet other people with the same age to talk with them and have new friendships and new relations.
No, no, doctor. We refused it. We refuse, and this is final, doctor. Doctor, no need for a nursing home, I think. I will tell my daughter to sit with him. It's all right.
Okay,
Um,
if you have someone to be with him, as this condition may recur again, because we are not sure about the diagnosis about the cause, and we when we after we follow the test that I told you about, then we can get more information about his condition. But
so what
um,
is that test exactly that he will gonna be discharged on it?
the test for his heart to see his um, how his heart is working and um,
Okay. So it's a kind
okay,
of a tracing for his heart again.
yes, tracing for his heart, yes. Okay, he is driving. He can drive. He drive.
Yeah, doctor, thank you for asking me. Yes, he's driving.
I have to tell you that he has to stop driving for now,
Hmm.
until we sure about his condition. And also, is he smoker?
No, he doesn't.
Okay. He drink alcohol?
Just occasionally.
Okay. Um, he has hobbies or hobbies or something he do in his spare time.
He likes he like playing piano, and that's it.
Okay.
And doctor, I want to ask you that can can these tests be done before he goes home, please?
Um, I'm so sorry to tell you that we have waiting list for this test, and this is done for the emergency cases at once. But now it is, yeah, it can't be because we are not sure about his condition, and he's okay now. It is not emergency. Is it okay with you?
Mm. So these tests are not like for people in his condition because he's stable.
Yes, and
Mm.
this is scheduled for people in a stable condition. We put him on the list, and he is waiting for time. Okay. Now
Okay.
I want to
Doctor,
ask you.
doctor, will he need a pacemaker?
For now, I'm not sure. We are not sure about the diagnosis, and yeah, we will discuss this when the diagnosis show up. Okay. Now, can I
Great.
ask you? Your home have stairs?
Yeah, doctor.
He must take care of these stairs because and he should be watched by someone as
Yeah,
when
you know,
this syncope and attack.
he will sit on the ground floor. I
Yes,
told him already
that's
before
very
you
good.
do. Thank you. Thank
That's
you.
very good. That's very good.
Yeah.
Also he can take care when watching TV and mobile, not in dim light. Or
Why, doctor?
um, this can aggravate his condition or cause
Okay, time is up. Dr. Sarah and Dr. Rhoda.
stress.
Well done, Dr. Sarah. Let's hear a comment from Dr. Rhoda, then I will comment. Okay. Yes, Dr. Rhoda,
Okay.
please.
Yes, yeah, you did great, Dr. Sarah. In the introduction, I think no need to tell, do you want anyone to attend the meeting with you? No need for the confidentiality issue.
Okay.
Okay. And regarding the concern, you answered them very great. You told her about the uncertain diagnosis. You are not sure at this point, but and at the same time you told her and you reassured her that his condition is not dangerous. You may tell her that we in this age we become afraid like from a heart attack or something, and this is ruled out. Regarding what else? You told him yes to stop driving. Yes, there is no at this point. You may not say like I'm not sure for the pacemaker. You are right, but you can tell her at this point there is no like evidence that he need a pacemaker, and by doing the rest of investigation, that this decision will be made like very clear if he need it or not. What else? Good, you ask her about the house, the condition in the house, about the nursing home. No need for a nursing home. You can tell her that if there is any family, anything, she will tell you, okay, I will bring my daughter to sit with him. If there is no family, involve the social worker. But I think no need like to nursing home. You can give her a safety netting, like including the, if he felt like any kind of a chest pain, awareness of heartbeat, just feeling dizzy, not only the collapse, just immediately uh, call the 911 or go to the ER and so on. Regarding on washing like things in a dim light and something, this mainly like to the epilepsy, I think, according to my knowledge. I think no need like to bring it here. But otherwise you did great. Thank you.
Okay. Thank you.
Yeah, thank you, Dr. Rhoda, for the scenario. Much better, Dr. Sarah, for the performance. You improving day after day, and the answer and the concern being perfectly answered. So we will start from the beginning, the comment, the introduction. You introduce yourself well. As Dr. Rhoda said, don't invite someone who will be exposed for a history of her husband. So don't invite. You can at the opposite side, you can tell her we get permission from your husband, but you cannot invite someone to be listening about her husband condition. Okay, take care of this. So whenever you are talking about someone else or another patient, to assume that you have permission and don't invite anyone unless the patient is already dead, for example, you can invite to break bad news, or he's in coma. This is the two only situation you can invite someone to sit with the daughter, with the wife, with the husband, to support her for the coming news because he already did or lost the capacity. He's not anymore conscious. This is the only situation you can invite. Apart from this, don't invite, okay? If the patient is conscious, this is his confidentiality, so don't break it. And you told her already, our meeting will be confidential, so it's confidential for her husband, and you should assume that you have permission and don't invite anyone to attend, okay? I think clear now, Dr. Sa.
Okay.
Okay. So this for the invitation. How do you know about his condition so far and the expectation? You did it great. The point of first time, did you don't ask about previous or history? Is this first time for him to have syncope? Whatever it's not written or written, no need to ask this question. This is considered as taking history, so don't ask this question. Then you go to the results. The result is with me now, or the results are with me now, and it's good news. Yeah, it's assuring news. Yeah, what do you think, doctor? Yes, yes, Mrs. Lisa. The result came as normal, or it doesn't show any disease Mr. Jones suffer from. So what he has, you can say it's some change of the alter or conscious level or awareness due to stressful condition happened to him. And I will explain to you why the syncope happened. It's called syncope, and the syncope happen when someone has stress, standing for a long time, panic for any trigger, or exposed to hot weather or standing in the sun, like that. Okay, this is the explanation of the disease. So it happened because of some triggers. What are they? We are not sure if there is something behind apart from the heart, because we did everything away from the heart. The brain shows nothing, no more electricity or no normal electricity in the brain, and the tracing of the brain was clear and intact. The problem now might be, but we will arrange an appointment for tracing of his heart to see what's going with his heart, and it will be as soon as possible. What are they? It's called Holter because it's clear. Holter and echo. Holter for tracing his heart for 24 hours, and echo to see the heart by a scan. That's it. Okay, Dr. Sarah? This is for the explanation. It will take from you 2 minutes, maximum 3 minutes. So this is the main bulk. This is your task actually in this case. Okay. She told you he lived alone, so you should address her concern immediately. No, he can't be alone in the coming days or coming weeks. He might have this attack again, and he might fall down. So what's the solution, doctor? What we can do? The last, even it's not the option. The nursing home, you can't offer unless she requested that. Please, doctor, can we arrange for his nursing home for the nursing home for him? Okay, we will try to do that. But from your side, what you can do, as Dr. Aruda said to you, ask for someone to sit with him, relative, I mean, daughter, son, his brother, any relative. If no, anyone can take care of him, any friend, he can live with him. If no, neighbor, but I guess the neighbor will be difficult because he will live with him, not physically with him. He's not only observing him or monitoring him. So it will be relative, the best choice. Then, if no, you can offer social worker, as Dr. Buda said. So this is the last. If she asks for nursing home, it's great from her side. Yes, we can arrange for that. But from your side, don't offer that. It means that you will isolate him to sit with the people. Yeah, it's good advantage to sit and stay with the people in the same age and they are talking together. What you did is great if she requested or if she asked you, please tell me, doctor, about other solution, and it might be accepted that if you feel that, okay? But if she didn't, don't offer it. Okay, great. You ask about the driving, the job, previous job, smoking, alcohol, and the stairs. I like when you ask about the stairs because yes, he might fall down from the stairs if he has this attack. The hobby, great you ask about, but some safety netting you can do. Like what? Please be sure that to advise him not to stand up for a long time, not to expose to the sun or hot weather, not to be in stress, not to be in panic. And if he's anxious for any reason, please try to calm him down. All these things or all these triggers might cause his attack of syncope, and by this safety netting, you can prevent this syncope from happening again. Last thing, leaflet brochure about syncope, and you arrange the meeting or sorry, the appointment for the next cardiac screening, I mean for the Holter and for the echo as soon as possible. We will contact you. This is our hospital contact you contact number. You can contact us anytime. And if he feel any symptoms like sweaty, like uh, uh, fainting or pre-fainting, you can bring him immediately to us. That's it. So you did great, Dr. Sarah. Yeah, I like when you insist to practice to get more experience and to be more confident. And please try to be more sympathetic and empathetic and to act more like talking in acting way. It's a show. I told you before, it's a show and it's so easy just to repeat and to practice more. Yeah, she did great, Dr. Roda. Yes. Telemetry is a jargon or not? Actually, Dr. Ihda, I don't know what the telemetry. Yeah, it's a jargon. Telemetry means the machine measure the EEG, I think, the waves in the brain. So you can mention only scans and image of his brain. No need to mention the telemetry. Even the Holter, if you want to mention Holter, tell him yes, or tell her we will arrange a Holter for him, which is direct to explain what the Holter. It's the device connected to his skin to trace his heart for 24 hours. The echo is jargon. So what after that you can explain what the echo. We will do echo for him. The echo is a scan for his heart by putting some jelly scan over his heart, and we can see the heart in the machine, and we can detect what's ongoing in his heart. That's it. Telemetry, you can say telemetry, but explain what is the telemetry. Don't mention any jargon without explaining. You can do it. You can say it, but immediately explain it. Don't leave the patient or the surrogate to ask you what is that, doctor. It will be against you. So the best thing to do, mention it, then explain it, or explain it, then mention it. We are going to do tracing of his heart through tracing electrolyte or sorry through some cables to connect it to his skin, and it will show us how the heart beat over 24 hours. It's called Holter. The same way, either pre or after, but don't mention without explaining. Okay. Any comment or any question? Telemeter, yes, jargon, telemeter, Holter. Dr. Dalia, telemetry Holter, are you sure? In the scenario, it's wait. What's written in the scenario? Telemetry show ACG, chest X-ray investigation. I guess I read the telemetry with the EEG. Okay, we will read about it. Telemetry equal Holter. Okay. Thanks, Dr. Dalia.
Good
Yes.
evening.
أهلين. Hello. Good
تليمتري
afternoon, Dr.
هو
Dalia. Yes.
أيوة تليمتري هو زي فكرة الهولتر مونيتور، بس الفكرة في شكل الديفايس، لكن same idea. يعني ده
Okay.
بيعتبروا الاستورج بتاعه بيفرق من الاستورج بتاع الهولتر مونيتور.
Okay.
ايوه يعني انا ما عارفه الفكره شنو، لكن ممكن للكلاود ممكن لكده، لكن ده عنده زي تشيب كده
And
بيكون.
patient.
ايوه ده عنده زي تشيب بيطلعها بعدين بيدخلوها عشان يعملوا تريسنج. في الاخر هم بيعملوا تريسنج للهارت بيت، فممكن
Yeah,
ببساطه
yeah.
يلاقوا يعني اتاش كويس والاتاش monitor for your heart to trace your heartbeat, the electricity of your hearts. Okay, this is a small device with battery. Okay, could be يعني hanged on your neck كده، بيلبسوه بحاجة كده في النك وبتتركب معاه فهي فكرة بتاعت انه tracing الهارت بيت، يعني electricity بتاعت الهارت.
So the main aim, yes, of Holter,
الاي اي
yes.
جي لا ما اسمه تليمتري، الاي اي جي مختلف. هو ما خدت اصلا في الديفرنشال بتاعه انه لانه هي كانت كونشس طوالي بعد الكولابس وكده، فما كان في شكله اكسكلودد. اعتقد برضو ايج زي ده هم بس حاكميننا، لكن احنا ممكن ناخد الفيزوفيجال اتاكس.
Yes.
التيل تيبل تيست كان ممكن يكون لوجيك برضو في الكيس دي. آم،
But
وكان الاي اي
we
جي،
will not mention it,
لكن هو ما
right?
خدتها شكل
Yes.
الكونسلتنت. احنا حنكون كوميتد للبلان بتاع الكونسلتنت.
Yeah, exactly. Yes.
ايوه فمحتاج شويه كده انه يشرح انه التليمتري ده شنو والايكو ده شنو، حتجي وين تعمل وين، بس انت هتشرح لها الحاجات التكنيكال دي، انه
Okay.
هنعمل ايكو، هنديك ابوينتمنت، هنحطك في فولو اب، هنحطه في فولو اب، هيجي للايكو والتليمتري هو 24 hours، بعدها بيجي المستشفى بيجيبوا بيفكوا له الجهاز
Reading.
ايوه عشان تريد التريسنج بتاعه.
Okay. Is it good advice to tell him good hydration and drinking plenty of water?
ايوه هو جود هايدريشن يعني.
If you
اعتقد
suspect vasovagal, I mean.
فيزوفيجال، هو ما اخدت الفيزوفيجال اصلا في حسابه الكونسلتنت.
So it was syncope only. Okay.
هو ما خدته ايوه.
Yeah.
هو
So
هو
only the task will be, yes, stick to the task. Yes.
ايوه استيكي للتاسك، احنا ما لنا دعوة. المهم انه
Mhm.
هو خاتم الموضوع ده mainly يعني heart problem we need to exclude. شكله
Exclude
exclude
it.
الهايبوغلايسيميا والهايبوتنشن والحاجات دي كلها excluded، او
Yeah.
الالكترولايت يعني كلها طلعها برا من البلاد تيست.
Mhm.
وبعدك عمل اي سي جي، فيعني حاجات الهارت بلوكس طلعت برا.
Mhm.
فضل حاجات الاريزميات التانية، كي البروكسيزمال اريزمياز
Yes.
والفالفولار ليجونز كده. الاسكيميك
Yes.
هارت ديزيز طلعها برضه.
Yeah. Yeah, I
اوكي
agree with you. Thank you, Dr. Dalia. Yes, so our task in this patient to rule out the heart condition or cardiac condition which is not diagnosed by ECG. So it might be something else, valvular or arrhythmia type or arrhythmia subtypes. So that we are done with this scenario. Let's go to the next scenario. Dr. Sarah, can you write your scenario, please?
I put it in the group.
Okay. Yeah, Dr. Amin saying echo is gel scan of the heart. Yes. Another comment, telemetry. Thanks, Dr. Ihda. About telemetry, heart monitoring, a wireless transmitter that display the patient heart rhythm and electrical activity at the central nurse's station, but may not display it at the patient bedside. Okay, so it's different than Holter, but it's the same aim. Okay, let's take Dr. Sarah scenario. Dr. Oda, prepare yourself. I will share the screen and you can see it from the screen. If you want to read it loudly, please, Dr. Rhoda.
Yes, okay. Hold on.
Yeah, I'm starting this share. Wait. Okay, now we can read. I will read it for you if you can see. Okay, your senior house officer in the acute medical unit, Mrs. Jack, 38 years old, was admitted to acute medical unit 3 days ago following a seizure at work. She suddenly collapsed in the lunch break and brought to the hospital by her co-workers. She was diagnosed with papillary adenocarcinoma of thyroid 2 years ago, and she subsequently underwent thyroidectomy and radioiodine treatment. She has been well for the last 18 months. A CT head scan was done on the admission, and it showed appearance highly suggestive of cerebral metastasis. Mrs. Jack is now feeling back to her normal self and expecting to go home later today. Please speak to the patient and explain the result of CT scan and plan for management. Dr. Rhoda, I will give you 2 minutes.
Okay.
Prepare yourself. Yeah, okay.
Yes, we can start.
Okay.
Yeah.
Okay, you can see the timer?
Yeah.
Yes.
Okay, start.
Yeah. Hello there. I'm Dr.
Hello.
Zain. Hello. I'm Dr. Zain, a senior house officer in the acute medical unit. Am I talking to Mrs. Jack, 38-year-old?
Yes, doctor.
Okay. Mrs. Jack, we are here to discuss issues related to your health condition. Is that all right?
Yes, please.
And before starting our meeting, do you want anyone to attend the meeting with us?
No, I'm okay.
At any point, if you have any kind of concern, please tell me. Is that all right?
Yes.
So to be in the same page, how far do you know about your health condition?
Well, doctor, I was admitted to this hospital since 3 days as I have like an abnormal movement and I suddenly collapsed to the floor while I was in work. And my colleague take me to the hospital and here I am.
Okay. Okay. And how are you doing right now?
I'm okay. Okay.
And what do you expect from this meeting?
Now I feel good, so I think I will go home.
All right. Thank you. Thank you for sharing this information with me. So, as I understand that you have been admitted to this hospital 3 days ago because an abnormal movement, we call it fits, and our team managed you accordingly, and now you are stable, and you are suspecting to go home. Actually, I have read in your notes that you had 2 years back of thyroid cancer. Am I right?
Yes,
Yeah.
but I took the treatment and I undergone surgery and took the treatment and I'm okay since that.
Okay. Okay. Actually, our team did a scan for your brain. We call it a CT scan. And actually, the result is now with me, and I'm afraid to tell you that it is not as we hope, Mrs. Jack.
What do you mean, doctor?
It showed that you have a cancer in your brain.
No, I'm okay. I'm now okay. I have nothing. I was expecting to go home and to go my normal life.
I'm really sorry. We revised it twice. This is our policy in the hospital. And I'm really sorry to be the one delivering this kind of news for you today. It seems that the cancer you had in your thyroid 2 years back has spread to your brain.
What do you mean, doctor? Are you sure? You really sure?
Yeah, we are sure. We revised it twice. That this result is for you, and I'm a kind of I'm very sorry because I'm the one who's giving you this kind of bad news today. But don't worry, we are here for you. We'll give you the best management plan that we have, and we are all here for you, Miss Jeff.
And what are we going to do now, doctor?
Okay. In this situation, actually, the cancer in your brain, obviously, is the one who causing you this abnormal movement that we call it fits. And what we need to do now, we will deal with you in a group of specialized team, including the nerve doctor, surgeon, specialized nerve. We call it Macmillan nerve, and we are gonna involve the palliative team. They are very like specialized in this situation, especially when someone had a cancer and spread to his brain. And do you want to hear further about this palliative team?
Yes, doctor.
Okay. Have you got any idea about it?
No.
A palliative team is a kind of a specialized team, including the nerve doctor, the surgeon, specialized nurse, psychologist, social worker, occupational worker, physiotherapist, and more. All of them will work together to give you best plan of management. They actually targeting treating the symptoms rather than to treat the disease itself.
Are you telling me that that you have no treatment for me?
I do really appreciate your concern. This kind of a palliative care is what is the best of interest for you that is decided by our consultant, and they actually like treat the symptoms rather than the disease itself. Because I'm afraid to tell you that your condition has already is advanced, and once spreading to your brain, this is advanced. I'm really sorry because I'm delivering those kind of bad news for you today. But don't worry, we are here for you. We will give you the best plan of management to improve your quality of life. Mrs. Jack, are you with me?
Yes, very good.
Yeah, and I would like also to tell you another thing. Do you have any other concern before?
No.
I would like to ask you, have you ever had appointed someone on your behalf to speak about yourself in case that you have lost your capacity?
No.
Or
No.
have you written like any kind of wishes in case that you lost your capacity?
No.
We're not in a
No, I
program.
didn't think about it.
Businesses need new developers, while other course providers have rushed to get their curricula online.
Okay, and then I would like to ask you further question if you don't mind. Do you drive?
No.
No. Do you smoke?
Yes.
Actually, smoking is bad for our health. I'm advising you to stop smoking. Do you think you can do this?
I don't know. Does it matter?
Actually, stopping smoking will improve our quality of life in many ways. And if you don't mind, we can refer you to smoking cessation clinic for this regard. Is that all right? Hello?
Okay. Okay, doctor.
Do you drink alcohol?
Socially.
Okay. With whom do you live?
Alone.
Okay. And what do you do for a living?
I'm a teacher.
Okay. I'm afraid your condition may affect your life and daily activity. We may involve the occupational worker regarding your job. And for living alone, do you think that any one of your close friends or family can live with you because of this like abnormal movement? If in the future when you are gonna be discharged, this will happen, do you think anyone can live with you?
Yes, I can arrange that.
Okay, thank you. And regarding that, I need to tell you that because of this abnormal movement, try to take a shower, not bath, and try to avoid like to be away from fire. And if you have like a swimming, better to be witnessed and avoid like sharp object and so on. All of this for your safety. Is that okay?
Okay, doctor.
Okay. Are you like plan to be pregnant or could be pregnant by any means?
No.
Okay. So I'm really sorry again for delivering those kind of bad news for you today. But remember that we are here for you to give you the best plan of management, including the follow-up and the management team. And I want to, we may give you like even a brochure to read more about this condition, about the palliative care and its importance. Is that all right?
Yes, doctor.
Thank you.
Okay.
Okay, and I want to sum up what we have discussed in this meeting today. That you have this, okay, time up.
Okay.
Yeah,
Okay.
time up. Yes, Dr. Sarah, please start
Yes.
comment.
Okay. You did good, Dr. Rhoda. Yes, you tell her everything, but I want to ask, don't you want to teach her about what is cerebral metastasis is? To say, hey, what about cerebral metastasis? What is this? The nature of disease and what it could happen, the symptoms, the complication, something like that.
I agree with you. I just told her in brief that she has a cancer in her thyroid, and it looks like it's spread to her brain. But I agree with you. I should like elaborate more. I agree. Thank you.
Yes, this is the only point you don't talk about, but everything else was okay. You gave her the safety netting. You address her condition. You was empathetic. Also, the multidisciplinary team and the plan of management was okay. Um, yes, everything was okay. And you said you talk about the palliative care. Yes, that's right. Only but the thing was the cerebral metastasis. What is nature? What is complication? And like that. Thank you.
Thank you.
Yes, thanks, Dr. Sarah, for the scenario. Well done,
Okay.
Dr. Rhoda. Uh, I will comment, then we will listen to other colleagues for other comments. Dr. Rhoda, you started the scenario well. The introduction was great, the invitation, because you are going to give her shocking news. So it was proper here. What she knows, the expectation, and how she feel now. It's also a nice question. I like from Dr. Sarah and you, the question is anytime you can ask me, you can stop me if you have any concern or any inquiry. Let's do that and train to do that every communication case. So the explanation, as Dr. Sarah told you, Dr. Oda, you started the explanation shortly and you didn't explain more. But the good thing you told her that the paper shows or the letter shows that previously you had a cancer in your thyroid gland and it was managed before. And the sequelae of this cancer that it was spread up. Sorry, before explanation, the breaking bad news. Yeah, the breaking bad news. You give the silence, the golden silence word. You prepare her by saying the result is not as we hope, but you didn't offer her anything. It was shocking news for her. You can offer her either water or tissue. Because I felt from Dr. Sarah like she's mad all the scenario. I mean, not mad. She was, yeah, she was like sad and yeah, she was shocked by this news. Yeah, you told her it's to being sorry to give her the news, but try to offer her something to support her. Are you okay? You want something like that? Just as act. We agree for that. We are acting in the scenarios and doing some shows. Explanation, as you said, the cancer in the thyroid, then it spread. But yes, better to mention more about the spread or the myths. It's called myths, and it's mainly from the main cancer in thyroid. And for this reason, your brain having some abnormal activity, which is causing this seizure. I'm so sorry to say that. And being spread to your brain means that it spread maybe to another organ and difficult to be managed. So our plan is, or our team and our expert team plan to what's called palliative, the palliative management, and you explain it very well. It's a team concerned to these cases and include 1, 2, 3, 4. What you mentioned, of doctor and sometimes GP, specialized nurse, family nurse, social worker, occupational health worker, and so on. And oncology, of course, the cancer doctor. And our aim, as you said, I like when you said, our aim is to make your life quality better. So she will definitely the cancer make her more worse in the future, but we will try our best to make the quality of your life better. However, It will not be that one better. The patient will be deteriorated, of course, but we'll try to be and reassuring after every bad news, it's a good thing. And don't worry, we are here with you. All this journey will be with you. We will support you as much as we can. We'll do our best to feel that you are comfortable and you will not suffer from any infection, from any pain, from any depression by including our mood doctor. And sometimes, if you need any team for your support, we can involve according to your need. So finish the palliative point. We will go to the lasting power of attorney and advanced directive. It's good to ask earlier here because this metastasis might lead to some change in hair capacity in the future. I agree with you. But the point of smoking and alcohol, as Dr. Sarah told you, does it matter? So I disagree to ask about smoking. Let her enjoy her last days or last weeks in her life, whatever. So smoking, whatever effect or harm, she will not be harmed more than the cancer itself. The driving, I agree 100% about the driving. It might have any seizure while driving, so it's good advice. The job, and you offer some support for her social, and if she is not able to do her work, yeah, we can involve our occupational team. The safety netting, I agree for that. You did it great, and you advise someone to attend with her, to sit with her. And pregnancy, yeah, I don't think she will think about, but it's okay to mention it. I guess we cover most of this point. The scenario is tough little bit because of the bad news and she being young. So try to reassure the patient as long as you are practicing this case. And at the end, offer her the leaflet brochure about this cerebral metastasis and the contact number of our hospital. And if you feel unwell anytime, don't hesitate to call us. This patient might be depressed in the future, and yeah, you should support her mood and try to be with her all her journey. Any point to be discussed or to be added from our colleague? Any comment or any question? Dr. Dalia, you want to add any point in this scenario?
Yeah, please.
Yeah,
I
sure.
agree with you. Well done for the case. But I want to just to clarify one point. In such case, when there is, for example, kind of this patient discovered by CT scan that he has mets in his brain. First, the CT scan showed that highly suggestive is a cancer. So I wouldn't say, yes, we checked twice and say that. I will say what is already written on the task. It's written that it's highly suggestive. It's metastasis or spreading of the cancer. So I just this is could affect the clinical judgment. By the way, be sure that you be it's accurate, because when you mention things in the task, it's accurate. They will give you a mark. If not accurate, they will deduct from you, because this is one on the already mentioned on the mark sheet for marking system. Okay, just be sure, be aware of that. Okay, and the second thing is that for after they discover that highly suggestive for cancer, that usually the consultant will refer the patient for the will put the patient for MDT meeting. That it's for they will invite the oncologist, the for example the neurosurgeon, and the all staff could be already treating the patient. Okay, and they will discuss that in the meeting, and they will come up of a plan, what the best plan for her, and they will come to her room to discuss with her the potential line of management, and they will see how the patient would like to be treated, and they will give her the options. For example, it could be radiotherapy in her case. Okay, it could be whatever, it's what kind of lesions. Sometimes there is immunotherapy treatment. Yeah, all of them are palliative. Okay, we agree that, but usually what we say, it's not straight away that it will be seen by the palliative. Just the next step immediately after this kind of scenario is your case will be discussed in a specialist meeting. It will include a cancer doctor, okay, and the brain surgical doctor specialist. It's better to say specialist, okay. The sounds on patient is very good, okay, to say specialist rather than doctor. It's better to say specialist. So cancer specialist, okay, and the surgical and brain surgical specialist, and the rest of the team, and they will discuss what the best plan of management invest with the rest of you. So after that, they will come to you here, okay, and they will discuss the potential plan of management. She's already know after the expectation, or after you will mention for her, for example, this is a spreading of the cancer. Usually the patient knows that is advanced, and then after that they will hit you with concerns one by one. What do you think that it's how long left for my life? All patients say how long left. At this point, you will say, this is early to predict right now. We need to be discuss your case. It depends of your plan of management and how, if there's any potential treatment that could, and how do you will respond to the potential treatment that is already. And sometimes from the start, the patient say, no, I don't want any kind of treatment. And some patients know they want to fight and want treatment, and they want everything to be done for them. So this is the next step, that your case, this is your investigation, will be they will be discussed on the meeting with a specialist to look for the best plan of management. Okay, after that they might ask you about the potential treatment. You will need to say that it's usually when the cancer is already spread to the brain, usually the options of treatment is not to cure the cancer, to prolong the life, to improve the symptom, improve the quality of life. So they might be chemotherapy, it might be radiotherapy, it might be any kind of immunotherapy, and it depends on what the best line of treatments is available in your such. They definitely will have the histopathology of the type of cancer, papillary cancer. I don't know what the line of treatment it would be, so it's immunotherapy is applicable or not. So this is the kind of thing, and you need in this kind of scenario to mention the palliative as an options of the palliative, and you are not sure what the best plan, and the best plan will be discussed with you. They will be discussed with you. Okay, so this is the usual plan in hospital, and after that you need to discuss the advanced directive. It's at this point it's better to be mentioned, but in very smart way. For example, usually they wouldn't discuss this immediately after this kind of news, but usually sometimes they could say, for example, we will sit with you again, and we'll need to explore and to discuss about future planning of treatment, and how would you like to be treated. If you say this, you already, if the examiner want to to listen, to hear this kind of, discussion between you and the surrogate. He will tick the box for you. That is, you are already tick the box of advanced lasting power of attorney. Usually in such cases, either advanced directives that I don't need this or this or this, or lasting power of attorney. But you don't need to mention this is in deep with this kind of news, and to put all this of information. It's difficult to take all this information together. So if you didn't go in details of these things, it would be good. And if you just give a hint like that, it's I feel it's better. As yet we will discuss. We'll come and discuss again with you about the future planning of management. How would you like to be treated in the future? Okay, unless it's mentioned in the scenario that it's almost days or weeks left, here will be urgent to discuss this kind of things. You got me? But it's not that very, very, very urgent. So I just will say some hint about that. Okay, that's it. Thank you.
Thanks,
Yes,
Dr.
Dr.
Dalia.
Dalia. Excuse me, Dr.
Yeah,
Faisal.
yes, sure,
Dr.
Dr.
Dalia,
Sardi.
okay. You are talking that we not talk in depth about the palliative care, right?
Yes,
Yes.
I would say if you said usually the plan of management after that, the potential plan of management from the meeting, usually the surrogate will ask you, is there is any cure for that or something. He definitely will ask you, the surrogate. This is one of the concern is already written for every such scenarios. And so she will ask you, and you could say yes, we will wait for the result of the meeting, okay? And we'll wait for the result of the meeting, and this is definitely will be discussed with you, but generally give her a general idea. But generally, when the cancer is already spreaded, particularly to the brain, it's usually there is no actual cure. I'm afraid to tell you that it's not curable, but that doesn't mean that there is no treatment for you. Definitely, there is some kind of treatment, what is called palliative treatment. Palliative treatment is intended to treat the symptoms, to improve the quality of life, to help you in your symptoms, okay? And it's it will prolong the life, okay? So if there is active palliative like chemotherapy, radiotherapy, or immunotherapy, this kind of palliative treatment, sometimes surgery. If it's only one lesion in the brain, they could do surgical removal. Okay?
Okay. This is because the scenario said show appearance highly suggestive and not stressed on the point to talk about palliative treatment, and this will be said um, directly in the scenario.
Yes, you need to
Mean
say
that?
it. Yeah,
You
it's
mean that?
highly suggestive that your cancer is already spread to your brain. So this is from the CT scan, it's shown that is highly suggestive. This is cancer spread. I'm sorry to tell you that. I'm sorry. I know this is shocking news for you, and some you need to be sympathetic and give her time, give pause to absorb this shocking news. And after that, we are here for you. We will be with you in your journey. Okay, don't worry. We will need to discuss this with the. Are you okay? Are you okay? And after that, if she start crying or something, okay, the usual thing, or no, sometimes the patient very practical, very pragmatic, and could ask you, okay, is any cure or how many left for my life? Okay, how many days left? What's the time left? Okay, this is the kind of thing. Just if you want to mention that the plan of management is very important. The plan of management is to mention that your case will be discussed in a meeting with a specialist to come up with the best plan of management. After that, they will come to you and to discuss the potential treatment options for you. And she will ask you what about that. Generally, it would be not to cure the cancer because already now it's advanced. So the intention is to blah blah. Yes, it could be. It depends on the kind. She might ask you, how could be? It could be chemotherapy. It could be radiotherapy. Give her some options. Okay.
I understand, Dr. Rodalia. Thank you.
Okay.
Thank you very much.
Sorry for lengthy explanation.
No. Thanks, as usual, Dr. Daria. Your sentences help us. So I will talk about the point of lasting power of attorney and the advanced directive. In Dr. Rhoda case, I think she found the time still adequate and she doesn't know what to talk about, so it's wise to mention it. Unless I don't have any point to mention or to discuss, I will not do that. I agree with Dr. Dalia, but if you have time, so what's expecting to do? Unless the patient or the surrogate give me more concern, like for how long I will live, like Dr. Dalia said. It will be very difficult one, but it's okay. We can answer that as Dr. Dalia said. We don't know the nature of this cancer. It might be longer, it might be shorter. Still, we don't know more about this cancer. So about after update, we can update you for this question. But it's difficult to answer this question by any way, because some individuals, some person respond, some persons and some patients are not responding. So it depends. This is one of the concern. Can little bit consume the time, but if not, I think, and we have time and like 3 minutes, we can raise it very shortly. This point. Sorry, I agree with Dr. Daria. If there is no time, no need to mention it. Okay. Yes, Dr. Daria, you want to
Yes,
add?
I mean, it's better to mention highlight about the plan of management. Not only this, the plan of management, it should be holistic. I mean, this is to explain to the patient that the plan of management, it would the medical side of medical side of treatment. Okay, that will discuss to potential treatment and so on, so on, so on. And the other side, it's we will be for like treatment, like palliative kind of treatment for the symptoms with potential, and the palliative team will see you after that. Sometimes the palliative team could come and see you. Okay,
Yeah.
and there is if any social, if any psychological, so this is holistic. So
Yeah.
it's need time not to consume about alcohol or smoking. This is not
Yes.
here at all.
Yeah.
The
Not here.
time
Yes,
it
I agree.
need to be consumed on with
And
whom
the
do you live.
palliative.
Yes, with whom do you live? Okay, I live with, do you need any care? Usually, this kind of people, if there is supportive family, ask, are there anyone under your care? Do you need any help at your home? For
Yeah.
example, if she has a small kids or her husband is, for example, it's paralyzed, for example, and she is the only one who take care of him. Here you need to know about the circumstances about the housing and how to, if you need any kind of care. Some people, they are independent, will be independent after this kind of like focal lesion with paralysis. They need care. They have no one with them. So it's need to offer package of care. What that mean, package of care? This is kind of sometimes package of care, it could be full package that their carer will visit the patient in their home. It depends on their needs. Sometimes full package of care 4 times a day. for breakfast, give the medication, and after that the tea time between the lunch and sometime lunch and sometime at dinner time. So it's 4 times carer visit the day. This is full package of care. So it depends. You need to offer package of care to the patient if they need to be someone to take care of them at home or to help them in housing atmosphere like washing, preparing meals. Okay, so
Yeah,
you need to dig more about this, and
the
this is
support.
not for now. Usually, if the meeting take longer time and the patient insists to go home, they could tell her by telephone or ask her to come for the discussion on like appointment meeting. And usually this is done during the hospital stay to discuss that with her, what the result, and to see what the potential treatment for her, and to just dig about the social life. It would be very helpful and very impressive.
Yeah,
Okay. Yeah, that's
yeah,
it.
yeah, I agree with you, Dr. Daya. Thank you. So let's have a question from Dr. Mahmoud. Let's start from the beginning. Dr. Hida, I think, asked question. Yeah, Dr. Tanya mentioned the point. Yes, not always palliative. Yes, I agree. Even the palliative word, it's a wide one. It's not only for the patient who's dying. Palliative means that we will do our best just to prolong the life and to support this patient and don't let him suffer more. Maybe he prolong his life, or maybe he live longer than we expect, according to the response either to the palliative chemo or palliative radio or palliative even surgery. So palliative is not meaning of death or expecting death soon. He might die, yes, but still we will do some palliative management, which are either chemo or radio or surgical. It's not necessary to die soon. The second, highly suggestive means uncertainty or confirm. So, Dr. Ihda, you can guess from the word itself, highly suggestive, but still not confirmed. The only confirm might be either histopathology or grading like that. But still, it's highly suggestive. As mentioned in the task, mention it, or the scenario, mention it. If they are saying highly, so tell here highly suggestive of malignancy. So what's written, you can mention it. But still, the cancer and the spread is highly suggestive of being cancer. The definite, as we know, the definite by histopathology to know what the kind of this cancer and the other spreading areas in the brain and the body, like liver and lungs, and every spread give more worse or worse, more prognosis. Okay, medical bracelet by Dr. Mahmoud. You mean for the seizure? I think she will be followed by a lot of specialists, so and she will be at home by anyway. She will not be active as we think. Yeah, I don't know to put it or no, but she's not living active like other patients. She'll be at home most of the time. Okay, if no more question,
I have one comment, please.
yeah, sure. Dr. Tania,
Yeah, yes.
yeah,
So
sure.
here actually, this scenario, they're telling that brain metastasis, but they didn't mention, as Dr. Jalia said, that it could be, I mean, if it is going for palliative or not. I agree that palliative, under palliative care, it's a big term. There could be palliative chemo, palliative radio, palliative surgery. But here we are not sure at what stage, because it could be a single metastasis which can be cured by surgery. Even some radiostatic nowadays, radiations are there, stereostatic. So that is also working and sometimes cured. So I feel like that if we answer it diplomatically without using the word palliative, just about that, our MDT team, that means our specialized team, including these doctors, and they will assess that how much it has spreaded. According to the staging, according to the spreading, they will have, like Dr. Dahlia said, agreed the potential plan of management. I prefer not to mention the word palliative, because palliative means it is not curative, right? So it's we are not sure still that it can be cured or not. So why should we decide from ourselves that it is the palliative treatment? Why not telling just diplomatically that there will be a team and there will be, according to the staging, they will take the treatment plan. So I don't know, I want opinion from you all.
Yeah, I can answer you this point, Dr. Tanya. Thanks for this question. As we used to see in the scenarios in the cases, spread or metastasis means that it's for palliative. Because even practical wise, spreading or metastasizing tumor carrying more worse prognosis, I mean. So what's your thinking? What do you will give here? Even single lesion in the brain, you don't know. Maybe there is another lesion in the liver, maybe another lesion in the lungs. It's not mentioned, but most of these scenarios, I mean the spreading or metastasizing tumor, most of them going to the palliative management. Anyway, you can do your diplomatic way, but you can mention it in another way. I mean, don't say palliative, but you can mention the teams who are treating or who are going to treat you to confirm and to be sure that you will not suffer a lot. But again, it will be mostly for palliative management. If you don't want to mention it, it's okay. If you want to mention it, it's okay also. For me, I will mention it because I hope also in the exam the scenario will be more clear, not only one lesion in the brain, and it will be for palliative management. They are clarifying the task nowadays. What you should do, they will write for you. They are not hiding or making like before hidden agenda, because before the old-fashioned hidden agenda, because you will sit with the patient for 16 minutes. So you are exposed to have any hidden points. But in our time now, it's 10 minutes. Your task will be clear. Do that and do that. 1, 2, or 1, 2, 3. No need to be hidden, at least some famous scenarios. But for this scenario, I guess the palliative is the best to be explained. Okay.
Thank you, Dr. Thank you.
Thank you, Dr. Tanya. Yeah, any other question or any other comment? Yeah, Dr. Dalia said brain metastasis. Yes, scenario said brain metastasis. So as I mentioned, Dr. Tanya, the scenario almost clear now. There is brain metastasis and your task is clear to talk about the metastasis, and the metastasis in medicine means palliative. Even in the palliative, when you manage the patient palliatively, it's not necessary to let him die. It's different than end of life care. Palliative means you will do everything to be sure that the patient is not suffering. Even if she will improve, they will continue the management. So I hope it's clear now. Take care to give false hope, Dr. Tani. Yes. So it looks many. Yeah, I agree with Dr. Tani. It's not it's a primary cancer. It means or it seems that it's secondary with a lot of metastasis. Okay, we can, if no more question, thanks all. I will stop recording to nominate for tomorrow session.